Assalamu alaikum. My name is Khwaja Owais and I'm here to give you an insight of how we manage tumors affected by motion in Cyberknife radiosurgery as compared to other conventional or 2D radiotherapy technologies. First of all, I would like to give you a brief introduction of what Cyberknife is. Cyberknife falls under the category of stereotactic body radiation therapy, also known as SBRT, under the field of radiation therapy. It has many advantages over older conventional radiotherapy. Because conventional radiotherapy has a rectangular field size or a customized field size if it has MLCs involved. But Cyberknife has a circular field size which gives us the ability to treat tumors as small as 5 millimeter in size, which is very precise, which in return helps us save healthy tissue and maximizes radiation to the tumor. Another advancement in Cyberknife, which is not present in older radiotherapy technologies, is that we have real-time X-ray imaging. Usually conventional radiotherapy doesn't have any type of imaging. We only rely on anatomical landmarks and tattooing to position the patient. In Cyberknife, we don't need any anatomical landmarks for accurate positioning. We have real-time X-ray imaging. Now, before I discuss you the motion management in Cyberknife, I like to give an insight what other modalities, how they manage tumor management. Like I said before, in 2D modalities, we completely rely on anatomical landmarks and anatomical positioning and tattooing. There is no X-ray imaging. So the physician and the medical physicist have to contour extra target volumes to compensate for patient movement, breathing movement, and any human error performed by the technologist while positioning. Some modalities, older modalities, have AP X-ray imaging, so we just have a initial position of how the patient is positioned. So, and on top of that, there is no software verification in older technologies. Now, in Cyberknife, we have two main methods to treat tumors affected by respiration. The first is synchrony respiratory motion tracking, and the other is Excite Lung, which is dedicated especially for lung tumors. Now for thoracic and abdominal tumors, we use respiratory motion tracking, which is one of the most advanced technologies in Cyberknife radiosurgery. Any tumor that is affected by breathing movement, such as lung mets, pancreatic, hepatocellular carcinoma, renal mets, and adrenal mets. The most challenging aspect is that how do we accurately track the patient, the tumor, and make sure that the radiation dose is delivered to the tumor only. A lot of you should know that in CT and MRI we use gating techniques to study the respiration of the patient. In Cyberknife, we don't need respiration gating techniques because the average treatment time lasts from about 45 minutes. So it is not practical for the patient to hold its breath for 45 minutes. To track the patient, we use fiducial markers, which are a type of pure gold markers or stainless steel screws. These objects serve as a reference to track the tumor because in Cyberknife we use X-ray imaging, and in X-rays we cannot see the soft tissue tumor. So these gold markers are implanted inside the patient's body around the soft tissue in close proximity to the tumor. So as in whatever axis the tumor moves, the markers also move, and these markers are completely in sync with the motion of the tumor. These markers are implanted using CT or ultrasound guided procedures. Now, after we have done the fiducial implantation and we are ready for the patient treatment, we make the patient wear a specialized vest called the synchrony vest, And on top of the vest, we attach LED markers which emit a frequency detected by a special camera that is part of the Cyberknife equipment called the synchrony camera. Now, if we are treating chest tumors in the thoracic region, we place these markers near the chest. If we are treating abdominal tumors, we place these markers near the abdomen. As the patient breathes, these markers breathe along with the patient, and then the respiration is recorded. This is the interface of how we treat and track the patient. As you can see, the boxes are the location where the gold markers are localized. You can see very small white cylindrical objects. These are the gold markers that are detected in the X-rays. In Cyberknife, we have two oblique right and left X-ray imaging so that we can track the patient in 3D. And now this is the same, this is a treatment of a patient that was being treated for hepatocellular carcinoma at Cyberknife JPMC. And you can see this is not actually a video, but a series of X-rays taken simultaneously, so we can study in how the tumor is behaving. If you notice, we cannot actually see the tumor, but we can see the gold markers. So these gold markers serve as a reference at whatever axis the tumor is moving. And these images serve as a complete respiration cycle for the patient. This is another interface that is in front of us when you're treating the patient. And in this interface, we actually study the respiration of the patient. Before starting the treatment, the first step is to record the respiration of the patient from complete exhale to complete inhale. And it doesn't matter if the patient is breathing ideally or irregularly, as long as the robot tracks the complete respiration of the patient, that means we have completely recorded the movement of the tumor. And then there's graphs to show us that in which axis the tumor is behaving, along the treatment, how much the tumor has moved from its position. So at whatever point of the treatment, we can study at where is the location of the tumor, even if we cannot see the tumor. This is the phase before we start the patient. This is a verification page which we can even between the treatment, if we are uncertain that the patient might be breathing very shallow or very deeply, or might be yawning or coughing, we can actually go back to the screen and study the whole position of the breathing respiration cycle, and can verify at what point we have to take a new X-ray image to make sure that the tumor is within our breathing range. Apart from that, we study the patient's respiration and the anatomy of the position. We have multiple parameters to make sure that the robot itself knows that it is treating the patient. So these are some of the parameters that we have to verify and adjust to make sure that the treatment is an accuracy. This is a brief explanation of these parameters. We have an X-ray reference image that we take from an initial CT performed before the treatment is started. And then that image is compared with the live X-ray images like I've shown before, two oblique right and left angle X-ray images. And then these images are superimposed on each other. So we have to make sure that as the anatomy as well as the markers implanted in the patient are completely aligned with each other. One of the most important parts in this position of these gold markers is that they have to be in close proximity of the tumor, so that we are sure that as long as the tumor moves, the marker moves in sync with the tumor. Confidence level in fiducial tracking. It is the level of confidence that the robot itself is how much the robot itself is sure that it is completely giving the dose to the tumor. At first, the technologist verifies that it is tracking the patient, and when we're about to start the treatment, the robot itself gives us that how much confidence it has that the tracking is being done. Oh, and then of course, There's a specific region of interest specified that the robot has to search these gold markers or the tumor within the specified range. Modeling points. When we record the respiration of the patient, we take images from the point of complete exhale to the point of complete inhale, so that we know that the complete respiration of the patient is being recorded. And along that cycle, multiple images are taken. Now the second method is X-site lung tracking. In patients with pulmonary meds, where there's a situation that we cannot implant gold markers, when there's a risk of collapsing the lung or pneumothorax, then we don't need markers, because the tissue density in lungs is much lower, and due to that, the higher density tumor tissue can easily be visualized with X-rays alone. So for alignment, we use the patient's spine for alignment, and then to track the patient, to track the tumor, we use the tumor itself. We don't need any external anatomical reference. If the tumor is large enough and it is dense enough, we can easily track the tumor without any external references. Preferred projection. In cases where we cannot visualize the tumor completely, the robot runs an algorithm that it assumes that the tumor might be in this position, and the robot does that confidently because because of the real-time imaging. We align the spine and we record the respiration of the target, and because of that, even if we cannot see the tumor, visualize the tumor that might be blocked by the shed of the heart, or due to the ribs we cannot visualize the completely, the robot calculates the similarities in both X-ray images and gives us the accurate preferred position of the tumor. In rare cases, we cannot completely visualize the tumor or even target the tumor. So during planning, if there is an instance that we can only visualize the tumor in only one X-ray, the physician and the oncologist that are responsible for the contouring and targeting marking of the tumor volume, they draw extra target volumes to compensate for this inability to visualize the tumor. And in cases where we cannot visualize the tumor in any of the X-ray images, the further extra margins are given along the respiration cycle. So we have to make sure that the patient respiration is completely recorded and the patient is completely aligned according to the parameters. And as long as that is performed, we are confident the patient is being treated accurately. Thank you.